Welcome to this introductory lecture on psychotic disorders and acute psychosis. I'm Andrew Penn. I'm a psychiatric nurse practitioner and an associate clinical professor in the UCSF School of Nursing. So now that you've met somebody who may or may not have had a psychotic disorder, let's talk about how common these disorders are and get clear on some terminology that we use in describing them. So in this module, we're going to define psychosis. We're going to talk about the symptoms and symptom complexes that we see in psychosis, and then begin to differentiate the diagnoses. We'll do this over the next several modules, and then we'll talk about assessment and management of acute and chronic psychotic disorders. So before we get going, I want to be clear about the language that we use, and this is important. We want, in psychiatry, to use person-centered language. So we don't use the term schizophrenic anymore. We use the term person with schizophrenia, or we talk about the disease of schizophrenia. We don't talk about somebody being a schizophrenic. This is really important because it's become increasingly clear that we need to differentiate a person's entire personhood from their diagnosis, and the diagnosis is just one thing that describes them, just like the color of their eyes or their hair. Now, what is psychosis? When I use this term psychosis, this is a term that gets used in kind of common language, and it's usually used inappropriately. So psychosis in psychiatry refers to specific symptoms that indicate a significant change in perceptual, cognitive, or the rationalizing functions of the mind. And that the person experiencing psychosis is experiencing reality very differently than other people within the same culture. And it's important to understand that. So when we look at, say, religious beliefs within a culture are not considered psychotic, even though outside of that culture they may seem peculiar. But as long as they are culture-bound, then they are not considered psychosis. And we'll talk more about some examples of that later. Now, it's also important to understand that the term psychosis does not indicate a diagnosis. It is merely a symptom, a descriptor. And underneath the wide umbrella of psychotic presentations or psychotic diagnoses, there are many different specific diagnoses. Now, intoxication, such as on methamphetamine or cocaine, or even alcohol or some psychedelic drugs, can mimic the appearance of psychosis. It can cause an acute transient psychotic sort of presentation. Medical surgical treatment can often cause a delirium. If you've ever worked in a post-op situation, you've certainly probably seen people saying all sorts of wild things as they came out of anesthesia, or if they were experiencing delirium, you've seen that on a medical floor. This is considered a psychotic symptom, but is not specifically a psychotic disorder. Delirium. Now, I mentioned in medical treatment a moment ago, I showed you here Kaiser Wildheim, who was the head of pre-World War I Germany. And I bring him up only because I had a patient years ago who was very confused on my med-surg floor, very pleasantly confused, old German fellow. And every time I would go in his room, I'd say, "Sir, do you know where you are?" And he would smile. And after a minute, he'd say, "No, I don't know." And I'd said, "What if I told you you were at Kaiser Hospital?" And he'd say, "Kaiser? We have Kaiser Wildheim." So that was an example of delirium, where the patient is disoriented as to where they are and what time in history they're in. So that is usually related to medical conditions, and is usually transient and clears up as soon as the medical condition underlying is addressed. Now, mood disorders with psychotic features, a good example of this would be bipolar mania, can sometimes come with psychotic symptoms, often kind of grandiose symptoms. This is, I'm trying to remember the name of the movie this was from, but this character is sort of obsessively jogging with his plastic garbage bag on. Oh, the name of the movie is going to come to me in a minute. At any rate, he had bipolar disorder and was manic. In advanced dementia, sometimes we can see psychotic symptoms emerging as part of that confusional state. And delusional disorders are fairly uncommon, but in delusional disorders, a person has a very fixed, specific belief that is not in line with the rest of everyone else's thinking. And you might have met somebody who had this in an earlier module. And then finally, probably the most well-known psychotic illness is schizophrenia. And we'll talk more about that in a moment. So all these have this significant distortion in the perception of reality and impairment in the capacity to reason, speak, and behave rationally. And also you will see impairment in their sort of spontaneous affect and motivation. Those are often affected, and people often have profound avolition and will spend all day in bed, for example, or when you talk to them, their emotional presentation will be very flat. Now, it's important when we see somebody with psychosis to differentiate, is this a new onset of psychosis, or is this something that, so when there's a new onset of psychosis, we need to understand, is this something that has been around for a while and is probably going to stick around, or is this something that has appeared secondary to another condition? So let me clarify that a little bit. When we talk about primary psychosis, we're usually talking about schizophrenia. So this is where the underlying disease is a psychotic disorder. Now, sometimes people can develop psychotic symptoms secondary to another illness, such as dementia or delirium in response to a drug, or, for example, something like an older person getting pneumonia can lead to them having enough confusion that they develop psychotic symptoms. We often refer to those symptoms as organic, whereas the schizophrenia spectrum and bipolar illnesses, for example, we refer to as psychiatric. It's kind of an arbitrary distinction, but it's one that you'll occasionally hear. Now, how many people have psychotic symptoms? Well, fortunately, less than 1% of the population, around 1% of the population, will develop schizophrenia at some point in their lives. But about 3 to 3.5% of the population will experience some psychotic symptoms at some point in their lives. And you can see the breakdown there. But probably schizophrenia and bipolar disorder are the most common psychiatric diagnoses associated with psychotic symptoms. And as you can see there on the right, they cause a significant amount of disability globally. So that's World Health Organization information about the daily lost activity years. So you see schizophrenia and bipolar disorder are right there in the middle of the list, with major depression being the top of the list. Now, psychotic disorders do appear to be heritable, although the quest to find the schizophrenia gene, for example, has been very frustrating. There does not appear to be any single gene that is responsible for psychotic disorders. And the challenge to most psychiatric diagnoses is that psychiatric diagnoses tend to be heterogeneous and subjective. We don't have good biomarkers, and so really we're making a diagnosis based on history and symptom presentation. Now, there are certainly candidate genes that are being looked at for conferring risk for psychotic illness, but to be clear, there is no one specific gene which confers that risk. However, it seems that schizophrenia does appear to run in families. Bipolar disorder tends to run in families. So a significant amount of that risk is actually heritable. Now, somebody can be walking around with this sort of genetic loading, if you will, for a psychotic illness, and perhaps never show symptoms of psychosis. And we think about this sort of stress diathesis model, where there's a certain amount of genetic loading and a certain amount of stress. And if there's enough of both of those, we can see an emergence of a psychotic illness. But somebody who maybe is very heavily loaded for psychotic illness, but never is under the stress of, say, leaving home or using recreational drugs, we may never see those symptoms emerge, or see them only emerge in a very mild form. But this idea that there's a cross-loading between genetics and stress is a fairly classic model. And we also know that schizophrenia, for example, tends to emerge in late adolescence and early adulthood, with male patients showing symptoms at a slightly younger age than female patients. But generally, as people get out of their 20s, out of their early to mid 20s, the risk begins to diminish. It's not zero, but usually that is the sort of peak time of schizophrenia emergence. And that happens to be the time where people are just getting started with their lives. They're usually just going to college, going into the military, starting to work. And so you can begin to see why this has such a tremendous disruptive effect on life course. So I think I covered most of this here. And the challenge, of course, is when we see somebody who is in their late teens or early 20s and is beginning to exhibit psychotic symptoms, the question is always, is this going to clear up or is this going to persist? Because I've certainly seen it go both ways, and we'll talk more about that in a moment. Now, often before the emergence of psychotic symptoms, there is what's known as a prodrome. Prodrome is the time leading up to psychosis, where the person may be starting to have very mild symptoms, which may only make sense in retrospect. It's oftentimes when the person has been developed florid psychosis for a couple of years, the mom or dad will say, you know, around his junior year of high school, he started to say some really unusual things, and we just thought he was kind of being a kid, but now that he's developed schizophrenia, it's actually making a lot more sense that that was probably a prodrome. So again, we think of this confluence of genetic loading and adverse childhood events potentially leading, sort of setting the stage, increasing the load that this person could develop a psychotic illness, especially if they have genetic predisposition. And then often this is a time of use where people are experimenting with substances. There are life stressors such as leaving home, going off to college, going into the military. And it's thought that the combination of all these confluent events can lead to a first psychotic episode, which often, if it's significant enough, and it often is, will lead to a psychiatric hospitalization. So there are opportunities to intervene all along the way. Obviously, we want to do everything we can in primary prevention to try and prevent adverse childhood events. We can't do anything about genetic loading, and we can also try and mitigate substance abuse, particularly cannabis abuse, which I'll talk about in a later module. And we can help young people, especially those who have high genetic loading for psychotic illnesses, to navigate the stressors of late adolescence and early adulthood, and even to manage the stressors of a post-hospitalization, post-psychotic episode. Now, we use this term schizophreniform, which means that the person is showing symptoms of schizophrenia, but they've had them for less than 6 months. So you cannot have schizophreniform diagnosis for more than 6 months. It's not like a hospice diagnosis where you can renew it after 6 months. At 6 months, you got to make a decision. But in this intermediate period, we call this a schizophreniform disorder. So the things that predict a more improved course, the less sick somebody is at the beginning is a good sign. The more they return to their baseline level of functioning, that's a good sign. Women tend to do better than men with regards to recovering from psychotic symptoms. And the fewer times that they get sick again, the better. And so that's also tied, of course, to fewer hospitalizations, but also to medication adherence. So the more we can get people on these medications and keep them on them, the better their course of illness is going to be. So there tend to be 3 courses that occur. So somebody has this first episode of psychosis, and they maintain kind of a stable course. They do continue to have some psychotic symptoms, but they're not getting worse. Now, there is another third of people approximately who improve and may fully recover from a psychotic episode without any further sequela. And then there are people who get worse as time goes on, for whom this appears to be a progressive illness. And at each stage of the process, there are different mortality risks. So at the very beginning, we worry most about suicide, because sometimes in this very distressing period of having reality begin to shift for a patient, they will get very distressed and may be at high risk for suicide. As the course goes on, tobacco use is endemic, unfortunately, among patients with schizophrenia, and that leads to later sequela, especially of cardiovascular disease. And some of the medications that we've been using in the last 20 years or so have a higher risk for metabolic disease, such as diabetes, hypertension, and dyslipidemia. So that becomes the later risks for the course of somebody with a psychotic illness, particularly schizophrenia. So in our next lecture, we're going to talk about the symptom patterns that we see in schizophrenia. Thank you for your attention.